Hello, welcome to my presentation. My name is Michael Joachim. I'm from the Oral and Maxillofacial Surgery Department at the Baruch Badeh Medical Center in Korea, also from the Israeli Faculty of Medicine in Bar-Ilan University in Safed. I want to present you today our research about the evaluation of relationship between preoperative soft tissue and its relative movement in orthodontic surgery. First of all, this is our medical center located in the northern Israel, Lower Galilee, right above the Sea of Galilee that we see on the background. First of all, I want to thank my colleagues and my collaborators for this research, Drs. Brosh, Abdul Razik, and Laviv, and also Professor Abu Naj from my department and from Tel Aviv University. And if we're speaking about the background for our research, first of all, orthodontic surgery, as you know, it's an alignment surgery, and we want to fix congenital and acquired deformities, and we want to try and solve chewing disorders, facial pain, and aesthetics. We need to accurately assess soft and hard tissue changes in the surgery before planning surgery, because we want to present our patients and to diagnose right the condition. We want to present our patients with how would they look like after surgery. The problem that we have with that there is a great variability in reports and lack of a great standard of how do we measure soft tissue. We have a lot of software of prediction for orthodontic surgery, but this prediction is very, very accurate and good for hard tissue. It's not very accurate for the soft tissue, and we don't really have clear answers. What is the connection between the initial thickness of the soft tissue to the outcome of the surgery? And this is basically the aim of our research, to examine whether the thickness of the preoperative soft tissue affects the degree of soft tissue movement relative to hard tissue movement after orthodontic surgery. So what we did is we did a retrospective analysis of lateral CEF X-rays of patients who did the surgery in our department between 2013 and 2018. What we did is we measured preoperative lateral cephalometric X-rays and then postoperative after 6 months. We superimposed them on fixed bony points, which is the SN line, the Sella-Nazion line, and we did linear regression to use to understand the relationship between various variables and degree of jaw advancement. What I want to explain is that we measured thickness between, for example, the maxilla between A point and A tack point, and then we measured preoperative and postoperative A point. This is the movement, of course, of the hard tissue. And then we measured preoperative A tack and postoperative A tack point. And we compared the degree of movement of A tack point compared to the movement of A point. And this is the correlation basically between the movement of the hard and the soft tissue. So first of all, demographics. We see here that the mean age is about 22 with a standard deviation of 7 years, which is pretty standard for orthodontic surgery. Most of patients are female. Over half of our surgery are tooth surgery, biomaxillary surgery, sometimes combined with genioplasty, and the rest are only maxilla or only mandible, and few of them combined with genioplasty. If we look at the distribution of preoperative soft tissue thickness in the maxilla, we see that the mean is just under 14 millimeters, and it goes somewhere around between 12 and 15 millimeters. If we look at trends, the overall we see that as thicker the tissue is, then relatively it moves less, but it is very, very clear seen in less than 5 millimeter advancement, when they have quite a good correlation between thickness in soft tissue and decrease in its movement after surgery. And we see here the trend of minus 0.288 in the R measurement. What we see in over 5 millimeter advancement, that there is no such correlation. Actually, it's reversed. And we think that because in that big advancement, soft tissue can't adjust itself even if it's thick, and it just follows the movement of the hard tissue. So here the correlation is positive As the soft tissue is thicker, then its movement is bigger, if I can say that. This is the distribution of soft tissue thickness in the mandible. Again, mean is around 11 millimeters, and 75%, mean 75% is between 10 and 12 millimeters. And if we look at trends, we'd see that overall there is no correlation between thickness and its relative movement. Same said for setback. Setback doesn't affect a different movement of soft tissue. But if we look at advancement of the mandible, we see that there is a clear trend towards less movement as the tissue goes thicker. The R measure is minus 0.4178. So once again, as tissue goes thicker, then it moves less after orthodontic surgery, compared, of course, to hard tissue movement. And as we look at soft tissue thickness at the chin, between Pogonian and Pogonian tag, we had only a few cases, only 6 cases. The mean is around 12 millimeters. It's again between 10.5 and 12 millimeters, the distribution. And once again, all the surgeries were advanced genioplasty, and we see basically a clear trend of less relative movement of soft tissue compared to hard tissue as its initial thickness arises. So, first of all, limitation of our surgery. We have here comparisons of outcomes in different types of surgery. It's an important point because we know that, for example, if we move the maxilla, it affects to a lesser degree, but nevertheless it affects the movement of soft tissue in the maxilla and vice versa. Here we try to isolate every one of the jaws, including the chin, and these comparisons are giving us some problems in our outcomes. We have a relatively small sample. We have, of course, over 30 patients in either of the groups, but the genioplasty group is quite small, and that's why maybe we couldn't do pretty nice trends. And the thing is that we took only patients that we had full data about them, and we didn't measure redo surgery. That's why we ended up with relatively small sample. And final thing, the precision of measurements on lateral taphometry of soft tissue is questionable. First of all, because we have superimpositions, we have complex anatomical structures, and it also depends on when and how the person who checked it puts the points and puts it into measurement on our software. But nevertheless, the precision is questionable, which is another limitation, weakness of our research. So, what we concluded. First of all, it shows a grand general pattern of decrease in relative movement of soft tissue in orthodontic surgery related to an increase in its initial thickness, which means the thicker we have, and the thicker soft tissue we have, the chances that it will move less after surgery compared to what we plan in the hard tissue. Our exceptions, first of all, big maxillary advancements in which I think we think the soft tissue just can't take the big advancement that moves along with it, and mandibular setback, which we also know from previous literature that there is no very good correlation between mandibular setback and the position of the soft tissue, of postoperative soft tissue of the patient. So what we plan to do in the future? First of all, we want to do larger study group, to do multi-center studies. We have a few things and approaches to do that. We want to stratify between different types of surgery to get as accurate result as possible. Thanks again to my colleagues, Professor Bolnaj, Drs. Labiv, Abdulrazik, Brosh, and Fadi Daoud. And finally, many thanks. If you want to contact me, this is my email. You can scan the QR code, get to my mail or to my LinkedIn. You're very welcome. Once again, thank you very much for your listening. And if you have any questions, please do not hesitate to contact me. Goodbye.